All right. Hello, everyone. Welcome to a Rafael Medina Cardiology Virtual Morning Report. My name is Maddie, and I'll be facilitating the session today. So I'm very excited for this session. We have two really phenomenal educators and cardiologists from Mayo Clinic who have joined the discussion today. We have Dr. Anavekar and Dr. Kashou. And I will jump into their introductions before we start the case. So we first have Dr. Nandan Anavekar, who is a consultant cardiologist and professor of medicine at Mayo Clinic. So he currently serves as the program director for the Cardiology Fellowship Program and has an avid interest in postgraduate medical education. So Dr. Anavekar, thank you so much for being here, and I'm really excited for the discussion today.
Thank you. Thank you.
And I'm going to jump into introducing Dr. Anthony Kashou, who is the founder and the president of the EKG Guy, which is one of the largest, fastest growing EKG warning resources and communities in the world. He's authored multiple books, including a children's book on EKGs, and has created over 1,000 educational videos. He's also the associate editor of the Journal of Electrocardiology and is the host of Mayo's Clinic podcast, the EKG segment Making Waves. And he's currently completing a combined NIH-funded research and cardiology fellowship at Mayo Clinic. So thank you both so much for being here. Before we go into the case, you both have done such incredible work in medical education and specifically with resources like the EKG Guy and Global Cardiology University. And I really wanted to use this time, to talk about those two resources. So for people listening to this who have not been exposed to Global Cardiology University or the EKG Guy, could you tell us a little bit about what those resources are, how learners can access the platform? Would love to kind of take a few minutes to learn about those resources before going into the case. So I'll turn the mic over to you, Anthony. Maybe you could tell us about those resources.
Well, thank you so much, Maddie, and the whole CP Solvers team for having us. It's really an honor, and Nandan and I have been looking forward to this, and thanks for the audience. And it's nice to be on sometimes the other side of things, because usually I'm the one in Maddie's shoes. But sharing and talking about medical education is one of, I think, our passions. All of us are joining today because we have that passion that yearning to learn more so that we can provide better care to not only our patients and our loved ones, but also advance the field. And I think, that's the mission that we kind of all come around. And so, just to give a little context of where I began, it was actually in medical school. Maddie's in her fourth year as I was in my third year. And I remember coming home to a stack of EKGs that my father had left on the table for me to interpret. My mom's like, yeah, Dad wants he left these here and he wants to go over them with you when you get home. Well, my father was an interventional cardiologist, still is. And little did he know I wanted to do cardiology, but I had no understanding. And all I saw were squiggly lines. And so if you have someone that you look up to, that a mentor, you want to make them proud. And that was a really low point, right? Because you wanted to do that. And so I found myself going to a lot of resources, books. You probably heard of Dubin's and all these even advanced ones, Marriott's Choose, a lot of EP books. And the whole process was incredibly inefficient because I found myself, some were saying use pattern recognition, use inductive deductive reasoning. But as a medical student, you still are trying to get through everything else. And so this whole learning process was incredibly inefficient. And I was like, I don't want my colleagues to have that same issue during their clinical training. And so fourth year, I put together with a cardiologist an ECG curriculum. And then after that was going and we do our away rotations, I started building. My life before medical school was tech development. And so I put together a website and very quickly found that others found them useful, which was great. And that encourages you to do more. And so that grew into hundreds of videos. And then I'm like, well, now teachers were asking for books. And so we started creating books, and then people wanted CME credits. So then we built a platform that added CME credits. And then instructors were saying, hey, I want to lead my classroom. And so the advanced analytics and how do you really adapt learning to the learners in the area that they are. And so this really evolved now into a social network. And so it's kind of a merge of, you can imagine, Netflix with kind of all of the EKG curriculum, and then kind of Facebook with the community, almost like Twitter. We have that social networking aspect, and that's kind of what we're trying to do. And my colleague here, Nandan, who you're going to hear and learn more from, and really humbles me in many ways. We kind of linked together and we formed what's called this Global Cardiology University. And the goal was, after you get out of medicine training, so after internal medicine, you go into cardiology, and it's a whole new world. And I felt like, and I still feel like I'm at really, even at the smallest point of my understanding of the depth of cardiology. But there's a real big gap because you're expected to, do what your peers are doing, but the knowledge gap is there. And so we wanted to really provide a standardization of a curriculum for cardiologists. And that's kind of where we link forces. And, from this point, it's kind of been so many collaborators, and we've now standardized the curriculum for cardiology, echo, we have ECG, and it keeps growing from flashcards to lessons and the community. So I'll let Nandan add to that, but that was probably more than I should have said, but thanks for listening.
No, thanks, Anthony, and hi to everyone. It's a great pleasure to be here. Especially as part of the Rafael Medina sort of series. What I would add is that when Anthony and I sort of got together to work on this, my biggest sort of problem when I was at your level was that I went to sort of the postgraduate medical education. You sort of had to jump around and try to figure your own way out, and it was really tough and intimidating. And so we wanted to create a curriculum that assumed zero knowledge, right, and sort of builds from the ground up. And that's really the premise behind GCU. So I would argue that any level of learner, as long as you value what you're trying to learn, can utilize the lessons and learn from that, whether you're in medical school, a resident, or a cardiology fellow. I think more powerful is we're sort of inspired by what you guys are doing, because we think learning should be in an environment. It should be a learning environment that sets up a community that's composed of educators and learners, both who value the knowledge that is being sought, and it should be a very safe space. And that's what we want to facilitate through Anthony's platform. And so we want to grow that community, and we want to what we call as democratize education, so that anyone who wants to learn should be able to access not only the content, but also the educators and their peers, and grow from the process. We've just did a series of podcasts with Dr. Ankur Kalra, that's on the parallax, and those are sort of crucial conversations within the medical profession. And we also think that should be a part of the community educational paradigm. With that, I'll stop, because I don't want to take away from the essence of what we're trying to get across here. But globalcardiologyuniversity.com, that's the website. And we just want to continue to see the community grow, and we want to share in your experiences and share ours with you too.
Yeah, thank you both so much. I personally am gonna, go to that website, sign up and make an account. I think the kind of how you described that, the threads of community building and kind of like accessible education all around the world, there's a lot of similar threads within CP Solver. So I know a lot of the listeners will be super interested. So we can now jump into the case. So Anthony, I'll pass the mic over to you, and you can share the first aliquot, and then we'll turn it over to Nandan to hear his discussion.
Very good. Thank you, Maddie. So the exciting part of tonight and what we've been looking forward to. So this is an exciting case, I think so. And hopefully the findings bring home a key message of things that you could take and pearls to use in your practice. So we have a 77-year-old female presenting with dizziness. So the chief complaint is dizziness, and it came on suddenly. She had some nausea, vomiting. She was feeling imbalanced, couldn't get around the house, and so she presented. Her past medical history included atrial fibrillation. She had a cardioembolic stroke back in 2005, so about 18 years ago, hypertension, hyperlipidemia. In terms of family history, there really wasn't much there. And that's where we really want to hammer away from a cardiology perspective of some of important factors that can contribute to this presentation. In terms of her social history, she did quit smoking 30 years ago, no alcohol use, married, still working, or retired at this point. And that's about all we know. In terms of allergies, none that we are aware of in her medication list. She's got a few of them and some cardiac related that we should be aware of. She's on hydrochlorothiazide, atenolol, lisinopril, atorvastatin, aspirin, warfarin for anticoagulation for her AFib, and some calcium. And so, I'm going to pause there, at this point, and maybe let Nandan weigh in to see, what are his initial thoughts given what we know at this point.
Okay. So sudden dizziness is what you said, right?
That's right.
Nausea, vomiting, and feeling unbalanced. Is it okay if I ask a few questions? Like any history of any recent viral illness?
Not that she has mentioned. No viral illness.
Okay, because and what do we mean by unbalanced? Like, did she have vertigo, or did she have any falls? How was the unbalanced sort of? I'm trying to connect this to a cardiac etiology right now. I don't see a primary cardiac differential with that limited history. Certainly, when you said cardioembolic stroke in the past medical history, you've got to think of, could this be a neurologic presentation? But first thing that comes to mind is, could this be like a viral labyrinthitis? But that's obviously not a cardiac diagnosis at this stage. But those are my initial thoughts.
So no cardiac things are coming to mind. Initially we have this dizzy presentation, and yeah, probably not the initial thing. In terms of her dizziness, getting around the house was difficult. I had a fall, but unsure if it was more mechanical or not in this case, and doesn't really live, or her husband wasn't home. She is married. No one was home at the time. And so this fall was kind of unwitnessed and unclear. Well, let's take a look at her labs, okay? So, basic CBC, her hemoglobin is 10.8, hematocrit 32. Her white blood cell count was 7.2, and platelet count 134. In terms of her BNP or electrolyte panel, her sodium was 137, potassium 3.5, chloride 101, bicarb 25, BUN 10, and creatinine 0.5. Are there any other, important things that you want? You're probably wanting the troponin, given that you're a cardiologist.
I wouldn't have got a troponin in the ED with these this sort of constellation, but I would think about, she's not diabetic, is she? There's nothing for a hypoglycemic sort of presentation. So maybe getting a spot glucose to make sure that's okay. Sodium is normal, so it's not some pontine related issue. With the severe nausea, vomiting, if you think about cardiac cause, the one thing that I'm thinking about, could this be a manifestation? Could this be a stress, which may be presenting as a stress cardiomyopathy? But right now, nothing is ringing out to me. I bet you a troponin was obtained. And I guess before a troponin, I'd probably get an electrocardiogram, because I would like to see some abnormalities in the ECG to guide me getting the biomarkers. Because right now, I wouldn't be thinking of an acute coronary syndrome, for example. That would be the first thing that you'd worry about. But she doesn't have the symptoms that scream out ACS to me.
Well, I agree with you. Let's go to the ECG. Maddie, can we pull that one up?
Yes, definitely. Let me go ahead and pull that up for you. All right.
This is the cardiac virtual morning report, right?
It is. So we have the electrocardiogram here. So maybe, Nandan, you can kind of take us through, like when you see an electrocardiogram, where does your mind go? How do you really approach it?
Sure. So I think number one, when you get an electrocardiogram, there's a couple of things. One is the electrocardiogram is meant to help you make a decision, which means that it should be coupled with the clinical story, and then helps you define the decision-making pathway downstream. When I approach an electrocardiogram, and you know, it's very humbling because I've got the EKG guy sort of watching my every word. But I look at you know, the rate and rhythm and axis first, and no matter how striking any abnormality might come at me, I try to be as systematic as possible. After looking at the rate, rhythm, axes, I start looking at all the intervals. I look at the you know, PR intervals, the QRS duration. I look at the ST segments, and then I look at the voltages, make sure there's, you know, the voltages are within normal limits, or if there's any evidence of hypertrophy or low limb or precordial lead voltages that might lead to an underlying diagnosis. When I look at this, I'm seeing an irregularity, and I think that there's probably atrial fibrillation being the absence of P waves. And Anthony has nicely, thankfully, put some arrows for me so that I can be assisted with my EKG interpretation here. Looking at the ST segments, and you know, there are some non-specific changes, maybe some slight depression in the ST segments, which brings up the specter of concern for ischemia. But having said all of that, looking at the ECG, you know, with the story that's provided, it's tough for me to put this together as a presentation of acute coronary syndrome. Indeed, if this is an acute coronary syndrome, this would be a very atypical presentation. But looking at these findings, I think we need to be cognizant and wary and maybe suspicious for an underlying ischemic etiology.
Very good. Yeah, and I'll just, you know, highlight, I agree with everything he said. And the arrows were to, you know, really question what he thought about this. Now, when we see this, especially for those maybe studying for your board exams, or just, you know, you think of the clinical context, a 77-year-old female with dizziness, and here we have the presenting ECG. Right, we know a little bit more than we usually get on maybe test settings, but she had hypertension, a lot of medications controlling that. And, you know, what do we see here? So the first thing I look at is the regularity. You know, so you see a rapid, irregular rhythm. There's really no clear evidence of P waves in this ECG. The ventricular rate, if you calculate it out, and I did this admittedly before, it was around 115 beats per minute. And so these findings, if we take them together, most likely suggest atrial fibrillation with a rapid ventricular response. Okay, now there are the ST segment depression. I put those arrows there in the lateral precordial leads. So that's V5 and V6 that I'm talking about. And, you know, with the patient's history, you might think, okay, when you see ST depression in the precordial leads, it's not normal. And so you have to think of, like, why do you see that? Well, in her case, you know, there may be some underlying hypertrophy. You see the large voltages, as Nandan pointed out. And so this could be just hypertrophy-related STT changes that are seen there. And so in this case, there might be some U waves. The, you know, potassium was 3.3, not super low, but maybe that's a part of it. We could see U waves in ischemia. So taken together, if we see what we have here, I'm not going to rule out cardiac causes just yet. And I think serial ECGs are warranted, at least at this time. So what do you think about a troponin? Should we do it?
You know, I think with these, you know, there are changes here. So this is not a normal ECG. I think we're sort of compelled to get a series of cardiac biomarkers. I think it's reasonable.
Very good. Okay, so just to give you the troponins, we did get a serial troponin, 0, 3, and 6 hours, and the first one actually came back undetected. So you wouldn't be wrong for not getting it. But, you know, we saw the ECG, we're thinking, okay, let's get at least maybe another one. Some people are saying the high sensitivity troponin may be a single rule out, but in this case, you know, with her history, maybe we're at least getting a 3 hour, and that came back at 0.1. So now it's positive. So less than 0.01 is the 0 hours, the initial one. 3 hours later, or it might be 2 hours later, usually do 2 hours, 0.1. And then the 6 hour one was 0.13. So you have a slow trend up in the serial troponin. And we have that ECG in mind that we mentioned earlier. Now, I do want to mention, maybe it wasn't clear, there was a possible fall. And I wonder what you're thinking. Is there any other, diagnostic test or imaging thing we should do at this point?
I would say, so was her clinical examination normal? Was there anything on clinical exam? So, so when I think about this, one thing that's coming to mind, could this be a stress cardiomyopathy? But remember, to make that diagnosis is a diagnosis of exclusion. The symptoms have all just been nausea, vomiting, dizziness. I would like to do at the bedside a Dix-Hallpike maneuver to see whether this is sort of an inner ear sort of phenomenon. I would do my best at a neurologic exam or get somebody who's better at it to do that to make sure that we're not missing any signs. I would hate to miss a stroke, especially if it's nausea, vomiting, and unbalance. You'd think about a cerebellar type of a issue. And if the clinical exam is entirely normal, and now we really have to explain the troponins. And in a 77-year-old with risk factors, hypertension, hyperlipidemia, even remote smoking history, I think the question becomes: is it some form of stress cardiomyopathy versus a bona fide ischemic syndrome? And remember, the troponins don't have to go sky high for us to have an acute coronary syndrome.
Mm-hmm. Well, I will give a little extra clues in terms of vitals. She was hypertensive. It was 162/92 when she came in. Her heart rate was, we saw it on the EKG, but I will give you a little clue. It was actually starting to trend down below that. And we have another ECG we'll look at here in a second. But in terms of exam, there wasn't a whole lot. Now, admittedly, my neurologic exam, there's a reason I did not go into neurology, is not great, but there was a little bit of pass pointing. The diadokinesis was actually starting to come play. So that alternating, that rapid movement was not on the initial exam, but coming soon, and a little bit of nystagmus. Now, again, you're trusting my physical exam, so be cautious with that. But her lung sounds were clear. I did not hear any murmurs, no rubs. Her temperature was normal, by the way, as well. So,
yep. So, I mean, what you're telling me is I'd be worried about a stroke.
Okay, so let's continue on. So, there was a CT had done, and there was no acute stroke, actually. No hemorrhage, no stroke found. There were some old lacunar infarcts that were present. Then she got extreme nausea. And at that point, we're actually due for another ECG, and hopefully Maddie can pull that one up, and we'll get your take on that.
Okay. Okay, so this is really interesting. The most striking finding is really deep symmetrical T-wave inversions. Now, this is what I would call as a unstable ECG. That's just the way I interpret these ECGs. When I look at this ECG, there are potentially four things that come to mind. The first, from a cardiac standpoint, is a critical stenosis involving the LAD. So if you've heard of Wellens sign, that's sort of what I'd be thinking about. Now, this is a little bit more dramatic, but what we're seeing is with that the ST segment change, the very deep T wave abnormality, that's sort of like our poor man's viability test. And when you have a critical stenosis, like a 99% stenosis involving the LAD, what this T wave abnormality shows is that you've got a live myocardium. And so that's one thing that comes to mind. Now, in this context, it's a little bit unusual, the distribution. So it may represent, for example, a critical LAD lesion, but which also supplies a chronically occluded right coronary artery. So number one, could this be an acute coronary syndrome? It doesn't quite match your story. The second critical issue is whether this represents an intracranial event. And now, before I go further, I'd like to know how quickly the CT scan was done before, since the onset of symptoms, because we could miss a stroke. Now, if you told me about nystagmus and pass pointing, and I think you said dysdiadokinesis, I would think about a cerebellar lesion. And the cerebellar lesion, because you're in the posterior fossa there, it's going to be pretty bony. So we might potentially miss a stroke. And maybe an MRI might be better to exclude stroke. But the symptoms are more, worrying about a stroke or an intracranial event. And again, this unstable ECG can be seen in that context as well. The third area I've seen this type of ECG is with a toxic metabolic syndrome. And the couple of times I've seen that is in cirrhotic patients who are encephalopathic. But even in that case, it becomes a diagnosis of exclusion. There's no sort of biomarker or metabolic panel that tells you that this is the cause. We still need to exclude critical coronary artery disease or an underlying intracranial event. But and the intracranial event, especially in an encephalopathic patient, is something that can only be resolved with imaging. And then finally, stress cardiomyopathy. Although I haven't seen this ECG presentation with stress cardiomyopathy, the electrocardiographic findings show a lot of repolarization abnormalities. You can see depressions, you can see elevations, you can see regional elevations, and you can see T-wave inversions. But again, these are quite dramatic. But given what you've told me and the signs, the clinical signs you've given me, even in the presence of a normal CT, I would want a neurologist at the bedside to make sure that they're okay, that this is not a stroke.
Yeah, that's very good. And just in terms of the ECG, I agree with everything you said, and that was a great differential. In terms of, do we have a lesion that's critically, stenose, or we have an unstable thrombotic lesion? You mentioned Wellens, for instance, and we're spontaneously perfusion. Now, we didn't give the patient any aspirin when she came in or anything. We weren't initially thinking that this would be, but I think that's a reasonable thing. At least now we see this ECG, especially now with the nausea. Now, with the things that we do, so objectively, what do we see? We see that we still have an irregular rhythm. The rate has slowed down a bit. We're coming into more of a normal range of ventricular rate. It's about 90 beats per minute. And so this is more of a, we have atrial fibrillation. You could see in the ECG, and those that are listening, there's a little bit of organized activity in V1. Now, I will caution you of calling that atrial fibrillation if you're only seeing that in V1. And so, the general rule of thumb is, be cautious of V1 when calling AFib or aflutter. You'll probably want to lean towards AFib in those cases. And because remember, V1 sits over that muscular chamber of that right atrial appendage, and sometimes you could see that occurring there. Now, there is the ST depression that we talked about earlier. It seems to be more at baseline, which can sometimes be concerning. And, the striking finding that you mentioned, there's now more prolongation of the QT interval. You have this diffuse wide T-wave inversions in the inferior leads, 2, 3, and AVF, as well as the precordial leads, most of the anterior ones, V2 to V4, and it's most prominent in leads V3 and V4. And so that's just a summary for those that are listening of what's going on. And so far we have this dizzy patient. Now there's extreme nausea going on. We see a trending troponin. The CT head initially was negative that came on, and that was actually done early on. So you asked, when was the timing? That was early on when she came in. And so, I guess what would you do next, Nandan? I have a few options here, okay? Would you, A, urgently cath this patient for likely proximal LAD stenosis or maybe an unstable thrombotic lesion? Would you get an echo to assess wall motion abnormalities? You mentioned and hinted at something earlier there. Would you get a cardiac MRI to assess for maybe myocarditis? Remember some of the context I gave you there and a question you asked early on, and then a brain MRI. Should we look for an acute bleed in this case? So what are your thoughts at this point in the case?
Yeah, I would. So I would, if I could put in another option, I would get a neurologist at the bedside because I'm pretty. If you saw nystagmus and dysdiadokinesis, those are pretty dense neurologic signs. And I would want a clinical assessment by a neurologist to say that there's nothing going on in the brain. And I think that's urgent for two reasons. One, these T-wave inversions, just say it's an intracranial event, they've been historically documented with intracranial bleeds. And so if we miss a bleed and we take somebody to cath and we heparinize them and we give them Plavix and aspirin, we could potentially contribute to their demise. So I would get a neurologist at the bedside before thinking about catheterization. I think echocardiography is a relatively benign procedure, and we can do that at the bedside. And now with point of care ultrasound, that should be done, but that should be done after we've called the neurologist and whilst we're waiting for the neurologist to come to the bedside. What was the other choices? Cardiac MRI? No, I would not get a cardiac MRI because that's just going to take too long. And I'm sort of worried, given this unstable electrocardiogram and her persistent symptoms and the neurologic signs. And then was there another option?
Cath.
Yeah, cath. I would not do cath until a neurologist has physically seen her and examined the patient.
All right. Yes, I would trust you, and I would do the same. I would get a neurologist because I would not be confident in Anthony's exam. So I agree with that. So let's just assume we have a competent neurologist, not myself. And, you know, the findings are still consistent. And you mentioned echo. We did get a bedside echo, and maybe Maddie, I don't know if you have those images. I'm happy to share them if not, but can we play some of those videos?
Okay. So so we've got a panel here of what we call as short axis images. So for you guys who might not have seen echoes before, the heart is sort of in a unusual position. And it doesn't sort of follow the symmetry of the rest of the body. So it's very difficult for us to talk about it in terms of, you know, coronal, sagittal, and axial imaging planes. And so we come up with some conventional imaging planes that we look at. And this first set, which you're seeing, the one that's playing, is in the short axis. That's sort of cutting across the heart. And what we're seeing, so that you see the left ventricle and the right ventricle. The right ventricle looks like that crescent that surrounds that circle, and that circle is the left ventricle. And we're high up, we're at the basal level, that's by the mitral valve, sort of annulus, and you can see the mitral valve sort of opening and closing there. At that level, maybe there is some septal wall motion abnormality, but we'd need to see the other levels play. Do they play? Okay. So this is sort of heading towards the mid-ventricular level. And at the mid-ventricular level, maybe there is some slight septal hypokinesis. So far, the EF is probably, borderline normal, which is reassuring. Okay, and so now we're right at the apex, and the apex is abnormal. The apex, maybe the septum and the anterior segment looks akinetic, and the anterior segment is the one that's close to the apex of that sector, or that point of that sector. And so overall, I'd say the EF is probably between 45 to 50%. So it's a little down. But do we know? Does she have a baseline? Is this old, or do we know? Or is this new? Do we know that, Anthony? Or
we don't know that. There's nothing in our system new to our system, and so this is all we have at the moment.
Okay.
I think we have a few extra views here that we can play.
Okay, so now what we've done is we've taken the probe of the echo probe, and we've gone to the apex of the heart, which is just in line with the nipple, in the sort of mid-clavicular line, fifth intercostal space or so. And so here what we do is with the probe, we get several different images, and as we're at that one space, we rotate the probe, so we get a look at all the different walls of the heart. So could you play that first one again? So this one is a 4-chamber view. So that bigger chamber is the left ventricle. And what I would say is that the infraseptum, I think, actually doesn't look too bad. And that septum is that between the left ventricle and the right ventricle. And then the opposite wall of that left ventricle is the anterolateral wall. And I think that's okay. But when you get out towards the apex of the heart, there's some hypokinesis there. The right ventricle in this view, probably normal size, probably normal or mildly reduced function. If you go to the second panel, okay, here, what we're looking at is the anterior portion of the septum, okay? And that part looks a little hypokinetic to me. And then the opposite side is the, if it plays, is the infralateral wall. And I would pass the infralateral wall. The image is unfortunately a bit foreshortened, so we're not really seeing the apex too well. But maybe there's some hyperkinesis at the apex. So right now I'm seeing some septal and apical wall motion abnormalities, keeping with what we saw on the short axis. Then with the final panel there, this is a two-chamber view that looks at the anterior wall, that is to the right of the screen, and then the inferior wall beneath that. And here I would say, if you play it again, maybe there's some hypokinesis of the anterior wall from the mid-ventricle down to the apex, but the inferior segment looks okay. And again, I'll probably give this a EF of 45 to 50, maybe closer to 50% or so.
Well, I'm glad you went through those all. I was going to say, did I have to be the one to the person that taught me echo or still teaching me echo, go through those? So yes, I would agree. And actually that was the estimated EF that you had. And so I could not have done a better walkthrough. So thank you for doing that. That was unexpected. Now, so just to come back to our case, we have the 77-year-old woman here with dizziness, and we had some sudden changes. The troponin was trending up. Her electrolytes weren't bad. Her potassium was a little low. We got a CT head. There was nothing initially. That was on initial presentation. And then we had the ECG changes. We got a neurologist that can do it, an exam at bedside, confirmed those findings, those physical exam findings. And, now we have this echo, okay, that we just had. And I saw a lot of great ideas in the chat that were coming in. So Nandan, what would you do next? Would you now take the person to cath based on what you saw there? Would you start heparin, load them with clopidogrel, and prep for maybe cath the next day? Would you initiate medical therapy for apical ballooning? We kind of talked. What would you do next?
Okay, so the echo doesn't look too striking for apical ballooning. I mean, there's some abnormalities there, and really to invoke apical ballooning, we really do need to go to cath. Now, I'm still unsettled by her neurologic symptoms. The thing here is there's no bona fide ST segment elevation, right? So I would not call this a STEMI, which means that I think we have a bit of time on our hand. And what I would say is I would try to have a discussion with the neurologist to ask, what is the definitive test to exclude a stroke? Are we okay with the CT head? I would say if we miss a bleed and we go to cath, we could create a catastrophe. So I would want some assurance by a neurologist that there's nothing more that needs to be done from a head imaging standpoint. If we get that assurance, then I think the next test would be a cath. In the absence of that assurance, or if they say we need to do a head MRI, even if that takes time, I would get the head MRI. And in contemporary, I went to a medical school where the only time you can get MRI is to exclude cord compression. We're much better now, and you can get an MRI in the middle of the night for a stroke. So I would get the neurologist to give me the assurance before going to cath.
Okay. And so based on what I'm hearing, you're concerned of something more urgent going on, rather this is more of and I saw that someone in the chat is this central versus peripheral and was leaning towards more of a central. Go ahead.
I would also just invoke that. I remember when I was a fellow, Dr. Seward, he's sort of like one of the fathers of echocardiography. And he said that with apical ballooning, you sort of see the apex ballooning out. And he said that you can also see cardiomyopathy with acute intracranial events. And that cardiomyopathy is probably related to the sympathetic surge that comes from that event. Usually it's a bleed, usually a subarachnoid hemorrhage that does that. I'm not getting that feeling that's a subarachnoid hemorrhage here. But with that sympathetic surge and the sort of variation in the beta receptors in the heart, the phenotype of the cardiac changes that you see with the intracranial event is more like a anterior anteroseptal infarct. We could, invoke that all this is one diagnosis. And if she's having a stroke, that could also explain the subtle echocardiographic changes and the ECG changes. And it makes sense with her clinical history and the clinical signs. I've never seen pass pointing or the nystagmus in somebody with an MI. This would be the first case of that. If we are assured that there is no stroke, then I think we are compelled. I mean, I think you have to take this patient to the cath lab, and you'd have to start heparin and treat for a non-STEMI.
Yeah, it's fascinating, and there are some components. But before I kind of give any other clues away, I kind of want you to make a little bet, and I'll give you 4 options, and maybe a 5th one, meaning it's not there. But if you had to make your bet, and maybe those in the audience, the chat can even chime in here, is what do you think this is? Would you say it's maybe A, coronary disease with severe left circulation stenosis? You mentioned apical ballooning syndrome. Could it be that choice? B. C, would this be an acute intracranial event going on? D, we mentioned apical or at least hypertrophic cardiomyopathy that could be present, or is there another option you're thinking? I mean, of those choices, where are you kind of hedging at this point? I know you asked for a little testing, but I want to see what your feeling or your gut is at this point.
Okay, without knowing the answer, I'd say that the conservative thing here is to assume it's a stroke. Because if you assume otherwise, we could harm the patient. This could be an acute coronary syndrome. I think my top 1 and 2 would be stroke versus acute coronary syndrome. But where can I do harm? I could do harm by treating this as an acute coronary syndrome and missing a stroke, especially if this is a bleed. The story, and when you say nystagmus, I don't understand how nystagmus is part of the presentation of acute coronary syndrome.
Yeah, I haven't seen that yet, but I'm the ill experienced, so I will trust you on not seeing that, and maybe we'll present a case. So, with that said, Maddie, maybe you can show him some of this head imaging that we got. So on the left, you have the CT, the initial one that they came in, and then day 3 is there in the middle, and day 2 you wanted your MRI. You got it. What do you think?
Look, I know there's an abnormality there. I'm not describing it, but it looks like it's in the cerebellum, right? Correct? I think
yeah,
so.
Right. Left pica region.
Okay.
Seems like, yeah.
And I don't know what this means, but did they see blood or?
It was a very large, stroke that they see it. I didn't have any comments on that, but yeah, I was a little shocked actually, and so I didn't have that gut sense that you did early on, and maybe I think it's the bias that we sometimes get, and that's another discussion that we should all think about is the field we go and how we're so biased in what we see every day, and I think your point in asking more questions, the history, as we're always taught in medical school, is like golden in many of our things. So hopefully with time I'm going to gain that intuition, that just that sixth sense that you have. But this was an intracranial bleed, and just to summarize some of the things we saw, these ECG changes have really been things that we've seen in the mid 19th 20th century, 1950s. We've kind of learned about those findings. And we highlighted those deep, diffuse T-wave inversions, but really you could see non-specific finding as well. As we mentioned, atrial arrhythmias. Well, this patient had an atrial fibrillation that we knew she came in with. Remember, she was on warfarin, so that's another discussion. What do we do with, all this? Now she's had another cardioembolic event, now a brain bleed. And so these diffuse T-wave inversions that we see that are wide and deep, especially often in the precordial leads. In this case, we saw them also in the inferior leads, are things that we could see with these neurogenic T waves, that prolonged QT interval. Sometimes the ST segment, it's sometimes non-specific changes can be seen there, but this is, I think, a really good case that we're seeing, initial ECG changes in dizziness. Remember, that's the main thing, she came in for. So, Nandan, do you have any thoughts that you'd like to share here?
Yeah, I mean, I'd say one thing. So you said, I hope that I can garner the intuition. What I would say is emphasize that I don't think there's an intuition here. I think that when you're unsure of something, so number one, I think the joy of being a physician is that it's sort of it's very intellectual, and it's like being a detective, right? So we all love the puzzle, right? That's number one. And so the puzzle only fits when all the pieces are in the right place, correct? And so here, this didn't really make sense with the story, because what you had is a clinical history that was very atypical for a primary cardiac issue. And in fact, when you first began the case, I was very, very stumped, and I was wondering which direction this was going to go. The second thing is the physical signs. So, I know we're in an era of technology, but please, please, please talk to your patients and examine your patients, okay? Make sure that your examination is complete, and it starts with the observation, the inspection, and then, don't just do a cardiac exam. Make sure you do a complete exam. Now, somebody who says they're unbalanced, you have to take them for a walk if they can walk. If they're talking about nausea, vomiting, I typically do that Dix-Holtpike maneuver, especially if they give a story that's concerning for maybe a labyrinthitis or some sort of a inner ear problem. So you've got to explain why the patient is feeling the way they are feeling. Then if the puzzle still doesn't make sense and you can't put it together, then the onus is on you to be safe. Okay, so safety is then the number one concern. Okay, you've got to ask yourself, what can I do if I don't think through it properly that could harm the patient? And in this case, if we assumed that it was all acute coronary syndrome because of the troponin and the ECG, and we gave somebody who came with the bleed who was on warfarin, and we started them on heparin, that could have been catastrophic. The patient could have died, potentially, right? So even in the absence of intuition, I think the goal is trying to put the puzzle together. If you can't seem to put the puzzle together, do what is the safest within your practice. And that safety also includes picking up the phone and calling people who might have a different perspective, because that can contribute to the subsequent decision making. Does that sound reasonable?
Certainly, yeah. And I would just echo the same things. It's the things we do at the bedside, getting the history from family members if we can't get it from the patient, and really getting that inner, professional, like getting our nurses. There's just different things that, once we start working together, a lot of things come together easier. And as they say, that the teamwork makes light work, and hopefully even solving some of the solutions like this. So thank you so much for participating. I know the dizziness kind of got you with bringing a dizzy case to a cardiologist. He's probably like, what the heck is this?
I was having palpitations when you said the case.
That's the next case now.
You handled it brilliantly. And one question I wanted to pose to you. So in this person who had AFib, who ultimately, had this bleed, how would you think through anticoagulation and kind of the risks and the benefits there with this person with AFib, but then developed bleed? How would you manage anticoagulation in that case?
Yeah, it's tough, isn't it? Because she's had a history of cardioembolic stroke, right? So that's a big indication to be on anticoagulation. and now she's come with a intracranial bleed, right? And so this is something where, there's no real algorithm. This is where it's really the art of medicine, and you've got to speak to the patient. Remember, the patient is the one that has incurred the stroke and the morbidity of the stroke. We have to see how the patient has gotten through. We have to be able to discuss with the patient that she would be at risk of a stroke either way, and being on warfarin may be a catalyst for further intracranial bleed if she has a substrate for that. And then I would cautiously, extremely cautiously walk down the road of other potential mitigators. For example, the Watchman device seems to be in vogue these days. I don't know if she's the right candidate. She may be the right candidate. But all of this begins with a conversation, and the conversation is not in one session. It's going to require a lot of follow-up. And so it's a tricky situation. And I think one way or the other, it's not without its risk.
Thank you for such a thoughtful discussion. And, before we kind of end the session, I wanted to turn it over to each of you to see if there were 2 or 3 learning points you wanted to highlight to leave with the audience. Maybe we can start with you, Nandan.
Sure. So I think this is a good example of a really more of a general medicine, keeping your sort of thinking hats on all the time. And I think it sort of does spark the joy of what we practice. So number one, you're all going into the medical profession because you are esteemed intellectual colleagues, and you also want to serve humanity in the best way. And the best way you can serve somebody is really to have their genuine interest at heart. And to have their genuine interest at heart, you really have to spend time with your patients. Okay, so spend time getting the story, spend time meticulously examining the patient, spend time thinking through things. Okay, it's not a race to get the answer. It's a collaborative approach. And when you're stuck, again, when the puzzle doesn't make sense or if it's not fitting, don't fall down on algorithms. Keep asking the question, keep pushing, and try to get a discussion going with other folks that can help out. And then the most important thing I'd say is make sure that with anything you do to a patient, ask yourself, what's the risk of harm? And you have to sort of weigh that risk because some of the therapies we do expose our patient to harm. And you've got to be able to make, a really thoughtful appraisal of that risk. Now, that risk isn't to you, but it is a true, genuine risk to that patient in the bed. And it's a risk that has to be juggled by the patient's family. So you guys are bestowed with a really great responsibility. It's a very humbling responsibility that you carry on your shoulders. And with that responsibility, it's also at the same time a majestic privilege. So wield that with respect and humility. That's what I would say.
Yeah, and just a few points from my end. They're not probably going to be as good, but I would say the anchoring bias. I think that's a key thing that I've come to find is important. Is be cautious of that first piece of information you get. In this case, it was dizziness. We came into play, as the troponins were going up, the ECG findings were occurring. And then all the stuff, things switch it to more of a cardiac perspective. But think of the whole case, and admittedly, the history could have been a lot more detailed, but we were limited on what we could get and what the emergency room got. So that would be the first thing, is be cautious of anchoring bias. Make sure you're really getting the history, because it's amazing how powerful that can be. And the other thing is, I have to say the ECG was a key player here, right? It gave us a solid differential of different options that we were thinking through. Now, it wasn't saying do this next step because, some of those steps could have been harmful, but it was a key player here. And so what I would really emphasize is that because we now know that less than 50% of medical trainees, meaning medical students, get ECG interpretation in their training, I would highly encourage to build up that skill. Learning ECGs is not initial just pattern recognition. I was told that it comes with time of building the skill, understanding the concepts, the foundation, and then using that as you move forward. And then the pattern recognition comes a lot easier. And so I would really encourage you, it's not an easy task, but spend some time trying to learn this skill. It's the most performed diagnostic test in cardiovascular medicine. So again, thank you to this team, CP Solvers. I always follow along and so proud of the work you do and this community you guys continue to build.
I'll just end. I'll just add one thing. As you were sort of talking, I just got reminded. I took care of a patient only 3 months ago. Patient was actually admitted to neuro ICU with a stroke, and he was a cerebellar stroke as well. And that morning he had a normal echo, and then I was called because he was having ECG changes, and then and he had some ST elevation. So went to the bedside, no chest pain, nothing. Okay, just the nausea. And so I was like, okay, this could all be because of the stroke. But then all of a sudden, the vital signs, you're starting to become hypotensive and bradycardic. And we didn't, bedside echo, EF was 25%. Okay. He was on the neurology service. So we said, is it okay if we take him to the cath lab? We took him to the cath lab. He had a history of cabbage, and his Lima to LAD was totally occluded. So again, it was just this case reminded me of that patient. It was only in the last couple of months, I think, but that was a case where he actually had coronary occlusion. So these cases are always going to be humbling, and just treat every patient uniquely on their merit, and just take your time and be thoughtful. And again, I'd also want to extend my gratitude to CP Solvers and to this edition of the Rafael Medina series. It's been an absolute privilege for me, for both Anthony and I. Thank you.
Well, thank you both so much for such an insightful discussion and really incredible teaching, especially on the EKG and the echo, when really just kind of balancing the uncertainty of this whole case. So I really appreciate your time and highly encourage everyone to check out Global Cardiology University, and I know that I will. So thank you both so much, and we'll end the session there.